Today's webinar is going to be conducted by Dr. Vidya Bhatt, and the topic for today's webinar is PCOS and infertility. I thank every one of you for sparing your time today, and I have great pleasure in introducing Dr. Vidya Bhatt to all of you. Of course, Madam needs no introduction, but I take the pleasure of giving a brief about Dr. Vidya Bhatt. Dr. Vidya Bhatt is a laparoscopic surgeon and infertility specialist. She is the medical director of Radhakrishna Multispeciality Hospital and IVF Center in Bangalore. Madam has conducted more than 100 live demonstrations on laparoscopic and hysteroscopic surgeries all over India. And Dr. Vidya Bhatt is the invited faculty at international level conferences to do live surgeries and lectures. Doctor conducts Endovision conference every year, focusing on skill development and recent advances. Madam has got a lot of credit in terms of the publications. She has got over 27 publications in national and international journals. And Dr. Vidya Bhatt has presented more than 70 papers in international and national conferences. All of you know Madam has held different positions. She was the president of KSOGA in the year 2017-18, Secretary General of KSOGA 2013-15, President of BSOG in the year 2012-13, and Joint Secretary of FOXI 2013. And Doctor is an ICOG member, Governing Council member of IAG 2015-17. And Doctor's Center is the recognized training center for reproductive medicine and minimal invasive surgery, that is endoscopy. Doctor conducts FOXI, ICOG recognized laparoscopy, hysteroscopy, and IVF training centers at Radhakrishna Multispeciality Hospital and IVF Center, and she has trained more than 500 students. That includes many of the international students from Nepal, UAE, Maldives, Nigeria, and Sri Lanka. And Doctor is very philanthropic. Doctor is running one Radhakrishna Foundation, which is an NGO for poor women and children. I'm very happy to inform you that Dr. Vidya Bhatt has adopted NR Colony PBMP Hospital under their Radhakrishna Foundation, and she is rendering infertility services to the unreached people. With this brief introduction, I am sure now every one of you will enjoy today's webinar by Dr. Vidya Bhatt. Over to Doctor. Thank you very much, Doctor, for sparing your time. Over to you, Madam.
Thank you, Mr. Balaji, for that lovely introduction. Thank you so much for giving me this opportunity to talk on this most debated topic, polycystic ovarian disease and infertility. I thank the SHIELD officials for conducting all this trial run and helping me out to do this webinar. Thank you so much. Good evening, everybody. I know in this COVID times, it is really difficult to take your time off, and I'm sure now all of you must have got into practice and you'll be seeing patients. My humble request to you all to take care, use PPE, use protective shields and masks, and take care of yourself. That is the most important thing, because we can take care of our patients, but don't neglect your protective devices. Use PPE, do COVID tests, and if you are in doubt, or even otherwise also, consider every patient as COVID positive and use PPEs. So with this small request to you all, I start my topic here today, polycystic ovarian disease and infertility. Now, there is a lot of debate in this. There's so much of arguments in polycystic ovarian disease. So, what is this disease actually? It is the most common endocrinopathies. It is multiple symptoms together and signs together. So it affects 6 to 7% of reproductive age women, and the causes when you see of a woman with infertility, when we think about the ovulatory causes, and that contributes to 40% of infertility for problems in a woman. And in that 40%, 85% of the women will have. So it is a major chunk of our patients who come to us with infertility. That is, most of them will have all this anovulatory problems and hyperinsulinemia, hyperandrogenemia, and then obesity. So PCOS is the most common endocrinopathy, as I told you before. India has witnessed about 30% cases in the last couple of years. So 20 to 30% will be in reproductive age group, that is PCO, and 5 to 10% in reproductive age group have PCOS, that syndrome itself. Among them, 87% will have oligomenorrhea, 26 amenorrhea, 50% will present with infertility, and 50% may present with miscarriages. Now let's just go to the definition to just complete. Now there are so many criteria made, 9 criteria. They said it was chronic anovulation and biochemical signs. 2003, the ISHRE ASRM Rotterdam criteria, they said that 2 out of 3, that is oligomenorrhea bar anovulation, clinical symptoms, and polycystic ovaries with other etiologies. So all this also could be. NIH in 1990 criteria, they said that major criteria for the diagnosis is hyperandrogenemia, and then those symptoms and menstrual dysfunction, exclusion of other disorders of similar clinical presentation. Then the PCOS criteria, they said it should be hyperandrogenemia, that is hirsutism, ovarian dysfunction, and exclusion of other androgen excess or related disorders. So when we go to the types, then when you have the types, there are so many. I mean, there is another lot of confusion because of the hyperandrogenemia, then the polycystic ovarian disease pattern, a pattern on ultrasound, whether they are normal looking women or they look externally they have hirsutism. So all these are confusions in PCOS. Let's just clarify this. PCOS phenotypes has been done to just avoid all this confusion. The Rotterdam definition includes 4 phenotypes of PCOS. The first one, that is A, group A, is hyperandrogenism, oligo and anovulation, and polycystic ovaries. So this is a full-blown syndrome, and they contribute to 45% of this PCOS. B is hyperandrogenism and oligo and anovulation. C is a little milder form. Hyperandrogenism is there, polycystic ovaries is there, but they are ovulating also. The D ones may not be hyperandrogenic, they look normal, but they can have all this prolactinemia and thyroid problems, and polycystic ovaries. There could be just correct the whatever lag is there. Yeah. So this is about the peripheral follicles. You just see the difference. A normal ovary, the volume is also less. The volume is also less, and the number of follicles, peripheral follicles, also is less. Whereas in a polycystic ovary, you have the number of follicles are also more. That is 15 to 20. On ultrasound, when you want to make a diagnosis, it is 15 to 20. And then the ovarian volume is more, and peripheral distribution of follicles is seen. Then the multicystic ovaries, of course, then it is distributed through, even this is polycystic ovaries. Then the possible sequelae. What happens exactly? There is impaired intolerance, dyslipidemia, non-alcoholic fatty liver disease, diabetes, hypertension, apnea, sleep apnea, obstructive sleep apnea, then they may go in for endometrial hyperplasia and CA, and then metabolic syndrome, cardiovascular disorders, then of course the mental problem. They have mental health also problems, anxiety, depression. So what are the causes? How does this happen to a woman? That is saturated fat deposition, obesity, inflammation, and chemicals, then hormone imbalance. Detection is morphological features, ultrasound and blood tests. All these irregularities, which I told you, hair growth, weight gain, everything. Symptoms, treatment is OC pills we have to give them, metformin, laparoscopy, diet and exercise. This is PCOS in one nutshell. Now, with all this preamble, let's go in for the discussion of PCOS. Now, the areas which I am going to discuss is pathophysiology, challenges in infertility management in PCOS, that is obesity, hyperinsulinemia, hyperandrogenemia. Then ovulation induction. What is the best way you have to do ovulation induction for these people and useful markers for management and conclusions. So the pathophysiology, as I told you before, increasing evidence to support the view. That is, there is a complex endocrine triad, contribution of several genes. See, there are so many genes contributing to it. With that, there is a jointly environmental and nutritional factors which also trigger this. That is, they should have a genetic problem with all CP17, CP11A, VTNR, etc. All these genetic features should be there. Then the environmental factors, their diet and the lifestyle, then the nutrition, what they're going to take, and then this PCOS happens and there is abnormal steroidogenesis. Then what happens is there is hyper secretion of LH. 40% of the patients with increased LH, they have menstrual disorders and infertility, and increased ovarian androgen production, which direct interferes with the oocyte maturation. So what happens is there is decreased ovulation rates and increased abortion rates, and then which will lead to decreased implantation and pregnancy rates in ART cycles also. So in obesity, what happens? There is insulin resistance, which is leading to hyperinsulinemia, and this the ovary theca cell hyperplasia is caused, and this acts on the liver. So there is decreased sex hormone binding globulin, which leads to hyperandrogenemia, decrease in insulin-like growth factor binding protein. So that also, because of increased insulin-like growth factor 1, so the binding globulin or the protein is decreased, so which in turn leads to hyperandrogenemia and then increased luteinizing hormone with obesity and anovulation. So this is a vicious cycle which is going on in that woman. So what does this lead to? Yes, ovulation. Even if they ovulate, there'll be anovulation. Even if they ovulate, the oocyte quality is poor, then which will lead to infertility. Then even if the oocyte is produced, fertilization occurs, the endometrial receptivity is decreased because these people will have hyperplastic endometrium. Then the implantation rates will be affected, so that is decreased, or there'll be no implantation. And this hyperinsulinemia also decreases the fetal viability, and after gestational diabetes and hypertension, this affects, I mean, even a healthy born live baby will not be there because there will be a gestational diabetes and hypertension affecting this lady. So these are the major challenges which we face, that is hyperandrogenemia, hyperinsulinemia, obesity, premature LH surge, and all these challenges we'll have to manage. And this is again the symptoms in frequencies, that is 80 to 90%, amenorrhea is there, acne they develop, alopecia also they'll have less than 10%, then infertility of course 40 to 50%, and overweight and obesity is almost 30 to 70%. So don't you think that do you think that only obese patients have PCOS? No. Even thin patients can also have PCOS. So when we see obese versus lean PCOS, obese patients have LH increase and the ratio is altered. Thin, it is even more. And here in obese patients, it is increased insulin growth factor and reduced sex hormone binding globulin. Here it is increased growth hormone in lean patients. Then hyperinsulinemia, insulin resistance is there, and here increased beta cell function and decreased hepatic clearance of insulin. Then insulin resistance as such is more in these people, whereas it is there but not much. Androgen, testosterone plus DHEAs, that's why these people have acne, whereas here it is only testosterone productions. Complications, of course, here it is there 30%, that is all diabetes, hypertension and all. Here it is less than 10%. So our strategy is to optimize fertility in women with PCOS. That is, we have to tell them to reduce weight. We should use insulin sensitizers. Ovulation induction is mandatory. Lap ovarian drilling in selected patients. Never go and do lap ovarian drilling in any ovaries you see, especially when young lab surgeons are trained. First thing they do is lap drilling. Please don't do it, and this will cause more harm. So in selected patients, yes, it really helps. And assisted reproduction, of course, if nothing works. So the course of action and the challenges which we face are: first line treatment, ovulation induction. Whenever a woman with PCOS comes, we do ovulation induction with clomiphene citrate and letrozole. Well, I have switched over to letrozole now. Clomiphene I used to give before. Tamoxifen I have just tried a couple of times and I have not got good results. Second line intervention, that is exogenous gonadotrophins and of course laparoscopic ovarian drilling. Suppose they don't respond to all these drugs, then the second line intervention, first try exogenous gonadotrophins. If they still don't respond, and if it is a thin patient and ovarian volume is more than 10 or 15, then only go and do ovarian. Please don't do ovarian drilling in obese patients because it really doesn't work. Third line, of course, we don't have a choice. We have to go in for IVF. Now let's take it by case scenario. A 24-year-old comes with complaints of irregular menstruation. She's been married for 1 year. Well, when they have irregular menstruation, they are really worried because there is a myth that you don't menstruate, then one may not conceive. Then she is grossly obese, 92 kg, with a BMI of 34. So how do we manage her? So management option is, because she is PCOS and obese. So what happens here? See, there is early follicle atresia, delayed mitotic maturation, increased aneuploidy, increased follicular apoptosis. Stromal desrealization, decreased endometrial receptivity, both are decreased. So there is increased leptin, tumor, TN factor, then interleukin, FFA, androgens, and estrogens are increased. Increased insulin resistance and hyperinsulinemia, which leads to infertility. Gonadotrophins are decreased and growth hormone is decreased in them. And then the sex hormone binding globulin is decreased. And in insulin growth factor binding protein also is decreased because of obesity. So obese women 3 times more likely to have infertility than normal women. 80% have increased BMI. Infertility rate is increased 4 times the BMI when we see. There is central obesity. When there is central obesity, then the conception rate goes down by another 30%. So when we compare the ovulation rate with the normal woman, when they are obese, it is 1.3 times and 2.7 times when their BMI is very high. So what happens here? Follicular fluid, insulin and androgen levels correlate with BMI in obese and fertile women, even in absence of PCOS. So increased BMI, increased androgens, premature follicular atresia, because you have seen multiple antral follicles. They are like a galaxy you see, but nothing happens. They do not mature. They just arrest there. So decreased follicular maturation and ovulation is the problem. Then of course there is increased adipokines. So then you have all this leptin and all is coming in the way. Then antagonize effect of insulin and insulin resistance is there. So the negative effects on oocyte development, embryo development and endometrial receptivity is there in these patients. So when you compare in normal, the the BMI less than 25%, 25 to 29 and 30 and above, the conception rate just goes down and ovulation rate also just goes down. So when we look at this complex clinical syndrome, that is genetics and lifestyle. You bring it together. Okay. The hormonal changes. Obesity exacerbates hormonal changes. So increased androgens, increased insulin, ovarian follicles, and anovulation, and there is increased estrogen. So androgens increase leads to hirsutism and acne. Menstrual disturbance and subfertility occurs because of the increased estrogen. Then you have increased insulin, diabetes, and metabolic syndrome. They go in for
Sure. Okay. 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 Uh, Excuse me, doctors. There is a problem with the network. So, madam will join now. Just wait. Madam will join so that now the audio will be also clear.
Yeah. Hello, can you hear me?
Yes, doctor.
Can you hear me now?
Yes,
Yeah.
madam.
Okay.
Yes, yes.
Shall I start?
Yes, madam.
Yeah. So I was talking about, yeah, I think they must have missed the previous slide. The connection with the obesity and the genetic and the environmental factors, which cause hyper. It's breaking. Yeah. Now is it okay?
Yes.
I'm audible.
Yes, yes, madam.
The screen is not visible, I think.
Screen is not clear. It is visible, but not clear.
Screen, my PowerPoint is visible, no?
Yes, yes, visible.
I needn't have to come. My PowerPoint comes, that's enough. And
Yeah,
my
it is.
voice is heard.
It
Yeah,
is there.
yeah,
It is.
okay. Yeah, okay. Thank you. Thank you so much. Sorry for the inconvenience. Yeah. So I was just explaining genetics, lifestyle, hormonal changes, that is, obesity exacerbates hormonal changes. So what happens? Increased androgens, increased insulin. Increased insulin leads to metabolic syndrome, that is diabetes, a cardiovascular risk. Increased androgens, hirsutism, and acne. Both cause ovarian follicles atresia or arrest, anovulation, and increased estrogen, menstrual disturbance, and subfertility, which once again leads to lot of psychosocial problems, body image, self-esteem, depression, and all these. Can that sound stop? That sound is a little. Yeah. So what happens in these obese women? We have to tell them to reduce weight. So 5 to 10% of weight loss can improve the insulin resistance, ovulation rate, pregnancy rate, and even BMI, decrease BMI to a normal range. I mean, coming towards a normal range. and no consensus or commencement of fertility treatment based on an optimal BMI. But ASRM recommends that BMI of less than 35 should be achieved before conception. The benefits of postponing pregnancy to achieve weight loss must be balanced against the risk of declining fertility with advanced stage. See, when we have a woman with 35 years and more than 35 BMI, we have very short time. So we have to hurry up. We ask her to go for 2 years and ask her to reduce weight and come, then that 2 years, it may not happen. So in such cases, we have to start treatment. Maybe if it is even more, if she puts on weight, then advise uh, bariatric surgery. So all these things which can be done on a fast track basis has to be told to these patients, because we can't waste time in any of our infertility patients. So as I said, diet, exercise, bariatric surgery may be considered for patients who are obese and PCOS, and when we have no time, when there is advancing age, you can't afford to give her 1.5, 2 years to reduce weight and come going to the gym and doing exercises, which is a little difficult. Then pharmacological treatment, it really doesn't help in weight loss. Somehow I'm not at all convinced with that. And of course, ovulation induction can be given, but bariatric surgery really helps. So weight loss is the first line therapy in obese women with PCOS, because sometimes obese women with PCOS, even at 92, 93, you ask them to diet and exercise, maybe 2 or 3 kgs loss, they develop a good quality egg and they conceive. Of course, the problems of conception and the problems of delivery and carrying on the pregnancy is secondary. But with that weight also, we see women conceiving. In fact, 100 plus also, they conceive when you give them ovulation induction. So you have to give them ovulation induction, because that a very good quality egg and a good endometrium will definitely help in good pregnancy rates. So this set structural training pattern. So that and hypocaloric diet, one group was seen. Then 2 weeks of observation followed by CC therapy, and exercise, diet, and ovulation induction. Ovulation induction with all exercise and diet gave good results. So that's what I'm trying to tell you, that we shouldn't prevent treating them. We shouldn't just ask them to go out of our vision and say just lose weight and come. They may gain weight and come. You have to continuously monitor them, motivate them to lose weight. So try doing, whenever you have such patients, try doing weight reduction, asking them to reduce weight with the diet pattern, exercise pattern, and ovulation induction. The ovulation rates and conception rates are better with this kind of treatment. Then we go to the second case of 27-year-old comes to the clinic with irregular periods, and she has facial hair, and she is obese with a BMI of 29 with acanthosis and insulin resistance. She is also planning to conceive. Then how do you manage for her? So we are talking about now hyperinsulinemia and hyperandrogenemia. So insulin resistance is present in approximately 50% of women with PCOS. So insulin resistance, hyperinsulinemia, type 2 diabetes, hypertension, metabolic syndrome, and then this becomes really complicated for them. 90% of obese women with PCOS have, obese women have insulin resistance even more, and this exacerbates ovulation dysfunction. So when there is hyperinsulinemia, you have to not only treat her hyperinsulinemia, but simultaneously treat her for ovulation, anovulation also. So in a normal patient, see how the glucose tolerance curve is, and in a PCOS, how it is. And when glucose stimulated with insulin, in a normal patient is like this. In PCOS, you see how they respond. So insulin sensitizers we have to give them. So the main aim of managing insulin resistant PCOS is with insulin sensitizers. Common drug used is metformin, dose of 1,500 to 1,700 per day in divided doses, but this causes side effects. And the criteria for clinical and biochemical evidence are hyperandrogenism. That is clinical evidence. You see all these hirsutism, moderate to severe inflammatory acne, then menstrual irregularities, acanthosis and clitoromegaly, alopecia sometimes. The biochemical evidence is free testosterone, then DHEAs to rule out adrenal androgen production, then sex hormone binding globulin has to be levels you have to see. Acanthosis and alopecia do not come under diagnostic criteria. They can be taken as high risk factors when you have to look out. Then once again, the issue is about stress. So they say that stress is something really scary linked between PCOS and the the lifestyle. That is, they have inadequate sleep, lack of physical activity, insulin resistance, hormonal imbalance, PCOS, and infertility. So they have to even learn to accept the kind of life they are leading, stay away from stress. So you have to even counsel them. Sometimes when they have such kind of problems, proper counseling sessions with a psychiatrist and a psychologist will really do good to these patients. So, or even you can spend time and counsel them for how to manage stress with them. Then PCOS pregnancy and trial, whenever we say in PCOS, pregnancy in PCOS trial, say they have tried CC plus placebo, metformin plus placebo, and metformin plus clomiphene citrate. So when seen that citrate is superior to metformin in achieving live birth rate in infertile women with PCOS, though multiple birth is a complication. You can't just give CC, but you have to give in a combination of that. So metformin is an effective treatment for anovulation in women with PCOS. Ovulation rates are higher when combined with CC, and it also reduces the risk of OHSS by approximately 75% and decreases E2 level, especially when you're giving for ART. That time you have to give them metformin because that decreases. These people are prone for ovarian hyperstimulation syndrome. So this will really decrease, metformin will really decrease, and there is lot of studies which have supported metformin decreasing the incidence of OHSS. Then this rosiglitazone, it has been used but associated with weight gain, less favorable pregnancy profile, and possible cardiovascular risk limit. They are, risk limit, they are used for this purpose. Inositols. Well, inositols, Mr. Balaji was asking me, Madam, will you cover this? Well, I am a strong believer of inositols. I give them in adolescent, I give it in reproductive age group, and even in the perimenopausal. That is, if there are women with 35 years with children with PCOS and who really want regular cycles, in them also I give inositols when they are really particular that we want regular cycles, we want OCPs. So that time I give them inositols, and the exact dose is 2 grams BD you have to give. So myo-inositol has to be given twice daily, 2 grams. So that is the best result which you can get. And I have given thin PCOS, I give them inositols, whereas obese, I give them metformin and myo-inositol combination. So we have got wonderful results with that. We have come out with papers, and the pregnancy rates are also very good. Though there is not much of evidence, which many people don't believe, but I'm a strong believer of inositols. Let's come to the case 3. A 21-year-old unmarried girl comes with irregular cycles, increased hair growth on the face. She's lean, and ultrasound shows bilateral PCOS. She's planning to get married soon, but not anxious to conceive. Management options. Well, in such cases, to help her to take care of a PCOS, we can give all these adjuvants. So what are these adjuvants? Glucocorticoids, that is prednisolone, and dexamethasone, which now is not given much, metformin, myo-inositol, N-acetylcysteine, then melatonin, vitamin D, chromium polynicotinate. So all this can be given. And of course, the 5 factors that cause PCOS, we have to really ask them to stay away from all this. That immune system, that bad dietary choice, genetic tendency, then accumulation of toxins, and of course, obesity, that is insulin resistance and obesity. So first and foremost, this is a lifestyle disease. So we have to really concentrate on lifestyle management. So role of treatment of hyperinsulinemia and hyperandrogenism, potential advantages, that is with metformin, we have so many advantages. Disadvantages are we have GI disturbance, feeling of unwell, decreased B12 absorption, and lactic acid buildup. So when we have seen all the papers and consensus in the meeting, it has proved in a large scale myoinositol does help in patients. So metformin. Metformin alone is less effective than CC in inducing ovulation in women with PCOS. No advantage of adding metformin to CC in women with PCOS. Use of metformin in PCOS should be restricted to those patients with glucose intolerance. Decisions about continuing insulin sensitizers during pregnancy in women with glucose intolerance based on careful evaluation of risk and benefits. So there are different studies, but the ISHRAE guideline says like this, but we have to give in a selected patients, especially in obese patients, metformin. But a combination of metformin and inositol gives better results in patients with PCOS, obese PCOS. So inositol is a member of B complex family of vitamins. It is an essential vitamin and it is manufactured in the body, but it tends to be deficient in PCOS. So that is why they developed this. Adults, of course, normally consume 1 gram per day, but it is present in all these bran, nuts, beans, fruit, etc. Free inositol is actively transported across the intestinal wall by a mechanism dependent on sodium and energy. Circulating free inositol is taken up by most of the tissue membrane associated sodium inositol transport. So all this is about the inositol, and PCOS is characterized by reduced level of inositol. So we have to give them, even if they are adolescents, because this hardly has any side effects. Adolescent PCOS with the infertility and reproductive age group. So there is increased clearance of inositol, decreased plasma inositol level, then insulin resistance and hyperinsulinemia and PCOS. So inositols, what do they do? Myoinositols. It increases insulin sensitivity, decreases insulin resistance, improves glucose utilization, decreases the free and serum testosterone, restores normal menstruation and normal ovulation, and improves pregnancy rate. So it has a lot of advantages, and this has to be used in a combination. So normalizes hormone, that is LH and FSH, insulin and even prolactin levels, decrease cardiovascular disease risk, increases HDL and decreases the LDL cholesterol. Suppose they are obese and they have lipid profile problems, this will take care. It also decreases weight to some extent. I mean, and BMI and leptin levels. So it helps to decrease their weight. When they take that and they're doing regular exercise and diet, the weight loss is seen significantly in them. So OHSS is decreased by this, improves general performance of reproductive axis. So to conclude, you have to take its usefulness in non-PCOS is still doubtful, but therefore it is should be used carefully in selected patients, of course. But inositols seem to be a promising molecule. So in treatment of PCOS with insulin resistance, not only in insulin resistance, with even ovulation, everything improves with inositols. So N-acetylcysteine comes from amino acid L-cysteine. So are building blocks of protein, improves insulin sensitivity and decreases androgen levels, prevents follicular cohort atresia, and improves the cervical mucus also. So this is used as an adjuvant in ovulation induction. It can improve ovulation and pregnancy rate and may be beneficial on the endometrial thickness also. So most of the time in PCOS patients, especially when you do a hysteroscopy or even a transvaginal scan, you see a thick, a triple line endometrium is not seen. Either it is echogenic, and sometimes you see small anechoic area suggesting a hyperplastic endometrium. So this endometrium has to be completely scraped off, and then with all these adjuvants, you start stimulation in the subsequent cycle, you get better implantation and pregnancy rates. So the adjuvants you can improve with insulin sensitivity and hormone profile. So it can be beneficial in improving ovarian response, ovarian stimulation, and IVF outcomes. Melatonin is a recent entry. So it's a hormone of the pineal gland, maintains normal circadian rhythms, governs release of pituitary gonadotrophins. So it is identified in anterior pituitary and ovary also. It is involved in follicular development, ovulation, oocyte maturation. Melatonin deficiency seems to be involved in the pathophysiology of PCOS. So let's come to this. So whenever there is a young girl who is not keen on uh, uh, conception, but she wants her PCOS to be corrected, she wants regular cycles, you can all add these adjuvants. Then you have a 32-year-old comes with infertility. She has irregular cycles and BMI 27. Previous evaluation done, husband semen analysis is normal. HSG shows bilateral patent tubes. She has received 2 cycles of OI with CC 1 year ago. Then what is the further management? You don't know whether she has ovulated or not. So anovulation is her problem. She might have responded to CC. You don't know about it because she has no records. So how do you consider when you have to just think about anovulation? So this is the normal ovulation mechanism, and this is what happens in PCOS. See, in normal ovulation, you see a nice dominant follicle. Whereas in a PCOS, the follicular development stops at this level, 8 mm, and then you have all these peripheral follicles because LH, RS, because, and increased LH, RS the follicular growth, and it goes in for atresia. In normal ovulation, you have the spike, the peaking up of LH you see, and then FSH, whereas here in PCOS, the LH remains high, FSH remains low. Throughout the cycle, it is maintained in the same mechanism. So anovulation in PCOS patients, you have hypothalamus, then low GnRH, low FSH, follicle does not develop at anovulation, strong estrogen negative feedback and very high levels of estrogen. So this prevents the FSH rise. So what happens? Strong negative feedback is there, low GnRH, low FSH and LH, and then no ovulation. So consensus algorithm for OI in PCOS, the Rotterdam criteria is when you detect anovulation, then you have to see to it that they ovulate. So when they are overweight, bariatric surgery and lifestyle management. So if you detect ovulation, then you see for some cycles and no pregnancy, then maybe you have to do further, IUI, assisted reproductive techniques. Then with CC, you proceed and you have ovulation. If the BMI is okay and you give ovulation induction, then ovulation is detected, but she does not conceive, then go in for IUI or IVF. Then you still, ovulation, it is resistant to clomiphene citrate or letrozole. Then you add gonadotrophins and try laparoscopic ovarian drilling. In spite of all that, she ovulates. Then if she doesn't conceive with your regular OITI or IUI, then you may have to take her for IVF. And IVF is GnRH antagonist protocol you have to use. So ovulation induction in PCOS, best practices, what we do is, that is depending upon the BMI, LOD of course should not be done routinely as I told you. You add metformin and CC, and then if necessary, if there is resistance, then gonadotrophins, and then do IUI. So the ovulation induction drugs are CC, letrozole, gonadotrophins, and adjuvants in ovulation induction. I have stopped giving CC. I have just shifted over to letrozole now, and if necessary, gonadotrophins, because the advantage with letrozole is you have unifollicular development, excellent endometrium, and the pregnancy rates are very good. So this is the complete, your platter of ovulation induction drugs. Tamoxifen, I'm not for it because I have not got good results. Adjuvants you can add, aromatase inhibitors, letrozole is the best. Gonadotrophins, of course, you can give. And then GnRH agonist protocol or antagonist protocol, I give antagonist protocol. So clomiphene citrate, of course, mechanism of action, I will not go into the detail of it. It binds to nuclear estrogen receptor, reduces estrogenic negative feedback, increases GnRH secretion, pituitary, increases pituitary gonadotrophin, and you have a ovarian follicular development. So the problem here is uh, you can have a multifollicular development. Second thing is the endometrium is thin, the cervical mucus is altered. Though we had conception rates before, sometimes there can be clomiphene failure. Clomiphene failure is from more different from clomiphene resistant. Clomiphene resistant is you give clomiphene citrate, they will not produce a follicle. Whereas clomiphene citrate failure is you give, ovulation may occur, may not, ovulation will occur, but they may not conceive. So that is clomiphene failure. So you start 50, you can go up to 200 per, 100 mgbd, that is 200 per day, and then you start from second day up to 5 or 6 days. Sometimes some people give it up to 8 or 9 days depending upon the severity of the PCOS. And of course you monitor with ultrasound. There are anti-estrogenic effect, that is what I was telling, that is on the endometrium, on the cervical mucus. The endometrial thickness will be less, reduced in glandular density, decreased uterine blood flow, and change in the quantity and quality of the mucus. And the miscarriage rate also is high, that is up to 26%. So as I said, clomiphene CC resistance, that is failure to ovulate after receiving the highest dose. It is mostly seen in obese, hyperandrogenic, and insulin resistant cases. So use of insulin sensitizers, a second line treatment you will have to do, that GnRH or LOD, extended use of CC, that is more days, not 5 days, you give for more days, use of aromatase inhibitors, addition with glucocorticoids, or pre-treatment with OCP. What you call is, we call it down regulation. What you can do is, you all know that follicles are recruited in the previous 2 cycles. So if you have to plan ovulation induction in a patient of PCOS, suppose looking at the ovaries, you see that it has not ovulated at all, you can downregulate with them with 1 to 2 cycles of OC pills, because this will bring down the LH levels and you get better ovulation rates and better conception rates. So sometimes when we, or if they don't respond to your letrozole or CC, you can put them on, counsel them and put them on, because you put them on OC pills without telling them, they may go to somebody else. But if you tell them that this is what I'm doing for you, I'm doing a down regulation for you, and when you say you're doing a down regulation and then subsequent 2 or 3 cycles later you start ovulation induction, you get very good follicles and conception rate is better. So obese women, management is obese women and lifestyle modification, as I said. Of course, failure, letrozole you give, in non-obese, if there is failure with CC, give metformin, letrozole, gonadotrophins, and LOD if necessary. So you can also do CC and gonadotrophin therapy. That is, you give CC and then you start gonadotrophins once it reaches 1 to 2, about 10 millimeters. If it reaches, then you can go ahead with the gonadotrophin therapy and then monitor the follicles. And once it reaches 1.5, you can stop your gonadotrophin therapy. So you should not use CC for more than 12 cycles, because there is 3-fold increase of malignancy. It is contraindicated in ovarian cysts, liver disease, and visual disturbances. So aromatase inhibitors, you have the first generation, second generation, and what we are using, anastrozole and letrozole. Of course, letrozole came and then it was taken off from the market, and later once again it has come back that all those studies which came were not true. So what it does, inhibits aromatase in ovaries and peripheral tissues, reducing estrogen levels. So that is why it is very helpful in obese patients. Say it because there is peripheral conversion. Whatever fat is there, that is converted and it increases the estrogen levels. When you give letrozole, because it acts like this, inhibits aromatase in the ovaries and peripheral tissues, reducing the estrogen levels. When that high estrogen level is reduced, you get ovulation and conception takes place. Negative feedback being active stimulus, hypothalamus or pituitary axis. GnRH release produces FSH. FSH mediated stimulation of follicle, rising estrogen levels from the follicle, and suppresses FSH, leaving a single dominant follicle. So what happens here is, once it gives that rise to some extent, then there is falling of FSH, which gives to a single follicular development. See, you can see here, negative feedback, hypothalamus pituitary, GnRH is released, FSH stimulation. So in this way, the FSH goes up, then it falls. So the smaller follicles which were developing undergo atresia, and you get a single follicle development. So that is the major advantage of letrozole. So the same mechanism of action which I told you, there is now in pictorial form, and this is how it acts. And when you give gonadotropin injection also, it does help in development of unifollicular development. So the duration of monitoring, that is, menses, you give letrozole and then you monitor the follicle development, and then once it reaches more than 18 and ET is 7 more than 7 millimeters, you give HCG and time the intercourse. So the conception rate is better, and 2.5 mg daily and not more than 3 cycles is not recommended. And TVS monitoring is recommended, of course, in all the cycles. I don't say in the first cycle. So ovulation rate is 75%, and pregnancy rate can go up to 17 to 20%. So earlier studies said that there were skeletal abnormalities, and as I told you before, subsequent said no. This I have come out with a paper on this, the step up protocol. That is, day 1 letrozole 2.5 OD, day 2 is 2 to 5, that is BD twice 5 milligrams. Day 3 is 3, day 4 is 4, and day 5 is 4. 10 again. That is, you give 4 QID. So this gives very good conception rates, and we have got 50% pregnancy rates. This is our study which we have done. It is in press. It will get published shortly in the Asian Journal. So this is, the miscarriage rate and the ongoing pregnancy rate is very good with this, and there's hardly any side effect, and it works out economical also, because you don't add gonadotropins. So this results are very good. So advantages of letrozole, yes, as I told you before, it is better pregnancy rates, it is superior to the gonadotropins, and monofollicular development is there, lower cancellation, and risk of hyperstimulation is less. There's hardly any side effect, and more rapid clearance, so thus leading to chances of preconceptional exposure and safety established in clinical studies. So this is about advantages. When you compare both, the advantages with letrozole is much better. You get a beautiful endometrium with letrozole. So management of PCOS with anovulation, of course, though you give other options, letrozole is one of the, first line of management, you can say. Lap ovarian drilling. Well, lap ovarian drilling, I have my own publication on this. It is in IOG journal, where I believe in multiple punctures, but this has to be done only to women with ovarian volume of more than 10. And then the current use should be cutting, not coagulation. If you use coagulation current, then the ovary is going to burn. See, this is how you do ovarian drilling. The volume was more than 10, high LH levels, thin PCOS. Don't go and do ovarian drilling on a obese patient. Do it on a thin patient. Within about 3 cycles, they can save. You have to stimulation in the subsequent cycle, but the follicular development and the oocyte quality is much better, and conception rate is very good. This, of course, 4 into 4 punctures, Armour's rule, I don't follow that, but I follow 40 watts and then of course use cutting current. This paper is I think 2012 or something. It was published in journal IOG journal, and we got the best original paper award for that. So the predictive markers for ovarian responses, FSH, AMH, and AFC, prospective cohort studies. So we know whether they are poor responders or whether they are high responders. AMH is done to know more of whether they are how their responses, than to know whether they are poor responders. So when AMH and AFC is increased, you know that they are they respond with multiple eggs. So AMH to be incorporated into workup protocols to predict patients' ovarian response and treatment. So even when there's previous history, or if you want to do IVF for them, it is better to do their AMH levels. So ART versus PCOS and non-PCOS, when so many cycles were seen in PCOS, increased cycle cancellation rate, increased risk of OHSS, increased number of eggs collected, lower fertilization rate, similar pregnancy rate, of course, similar miscarriage rates. So IVF stimulation protocol. So how we do, then whenever you do a long or an antagonist protocol, whatever you do in them, the success rate does not matter really, not significant. But the big difference is the hyperstimulation rate. With antagonists, you have complete control over the cycle, whereas in agonist protocol, you don't have control over it, and then we'll end up cancellation and all the problems we face. So gonadotrophin's indications, all these: persistent hypersecretion of LH, letrozole failure, letrozole CC and letrozole resistant, when you want to do IUI cycles or ART cycles. Sometimes I use letrozole even for low cost IVF. That is, we give first 5 days of this step-up protocol, and then we add gonadotrophins on the 8th day. So we get about 4 to 5 follicles. Of course, we don't have any, the embryos to freeze, but we have got good conception rates in that. So when we want to do a low cost IVF, I use step-up protocol with letrozole. So it can be used alone in conjunction with CC and letrozole, depending upon the BMI and the response. So gonadotrophin selection, that is a biggest challenge. So selection, do you give HMG or highly purified or urinary or recombinant? Well, when you're starting this, if on day 2 LH is increased, then go in for FSH, that is recombinant. Suppose the FSH is increased, then you have to add HMG also. So you have to monitor the LH levels and E2 levels, and depending upon that, and try to keep the LH at around 2 and 3 max, because in PCOS, suddenly the LH can go up. So we have to control the LH. So to control the LH, you have to give recombinant FSH, or if you feel it is expensive, urinary FSH or highly purified FSH. Whereas when they have increased FSH, try to add HMG, because LH also is necessary for maturation of oocytes in PCOS patients. So we have to do a close monitoring of everything in this LH, progesterone. So maximum of 6 cycles use urinary FSH, highly purified, recombinant, and there was no difference in the terms of pregnancy outcome and risk of OHSS. Pregnancy rate 20 to 25%, multiple pregnancy rate 10 to 30, and OHSS 2%. So step up regime. So the question always arises, do you want to step it up or you want to step down? Whichever you want, you do. Conventional step up is 150 international units of 75 units of LH and FSH. Increase every 3 days by 50% until ovulation. Ovulation rate is 70%. Cumulative pregnancy rate is 21 to 70%. And OHSS, of course, and multiple pregnancy is there, and multiple pregnancy rate is high. Low dose protocol, that is increasing FSH in gradual stepwise fashion, allows rescue limited number of follicles, mirroring that of a normal hormonal cycle. That is, you start with 75 and then you start increasing from day 7, the dose by 50 to 100%. A dominant follicle 17 mm when it reaches, give HCG 5000, or you can give a dual trigger We give a dual trigger when we have PCOS, and uh, uh, we give antagonist cycles. So we give a dual trigger always with the antagonist, that is 2 milligrams of glupride we give. And if no response, FSH has to increase, and you should increase uh, increase the number of days of gonadotrophins. So chronic low dose protocol. So the principle here is the threshold curing, attainment and maintenance of follicular development with exogenous FSH without exceeding threshold requirement in order to achieve a single dominant follicle. So initial dose of FSH extended to 14 days, and weekly increment reduced from 100 to 50%, and then 3.75 IU. So safer for monofollicular development in 70%. This reduces OHSS. And the drawback is you keep on monitoring, the patient gets bugged because it will take about 28 to 35 days for the follicle to develop. So the patient will get very upset with you. So FSH day 375, then day 7 follicular, maintain the same dose, then you have 3.75, and then you just continue that and increase the dose if necessary. And if follicle increases, then maintain the dose and give HCG treatment. So step down principle regime is to achieve FSH threshold through loading dose of FSH followed by subsequent stepwise reduction with the dominant follicle. Physiological is natural intercycle FSH rise with reduction in the independence of developing, that is dominant follicle to FSH monofollicular development. So a step down protocol is like this. You start with 150, then you decrease to 112, then 75, and then continue until HCG. Sequential protocol, of course, you maintain FSH for 7 days, look for follicular development, increase the dose just by half to 14, and more than 14 when it reaches, you start decreasing the dose and maintain 75 till dominant follicle and give HCG trigger. So how to prevent OHSS? So the 3 main steps are use of GnRH antagonist protocol, and instead of a long protocol, ovulation triggering with GnRH agonist instead of HCG. You have to give a small dose of HCG. So even if you give an agonist trigger, give a small dose of 2000 international units or 5000, depending upon the E2 levels, and post the follicles and bring it down, bring the E2 levels below 3000 or 2500, then only you give the trigger. And cryopreservation of all oocytes and embryos. So this has to be done. And you have to be very careful with low BMI young patients. So they are higher risk, they have higher risk of OHSS. So prevention of OHSS, primary and secondary, reducing the exposure to gonadotrophins in primary, GnRH antagonist protocols, avoid HCG for luteal support. I don't think anybody gives now. And IVM, if at all, insulin sensitizers, as I told you before, metformin. And of course, myoinositol also. I believe in myoinositol. And secondary, coasting, and then decrease HCG dose, freeze all. And GnRH agonist trigger, and others, of course, anti-salvage, dopamine, and all those things you'll have to do. So preventing OHSS, of course, is definitely better than cure. We should not have a case of OHSS in modern IVF clinics. So prevent early and late onset. Single embryo transfer with blast reduces the risk of multiple pregnancies. Impaired endometrial receptivity due to supraphysiological steroid levels. That's why freeze-all. RCT showed that 7.3% increase in live births following FET and increased pregnancy fresh transfer. To avoid embryo exposure to higher steroids, you have to freeze all. So that you have to keep in mind. And then PCOS patient, should we use donor oocyte? Well, if the oocyte quality is poor, if you have a poor quality embryo, that is, you have fragmented embryos and repeated failures, then you should use donors in PCOS. That is the first thing. And then second thing is, women with PCOS should not be excluded for oocyte donation program. That is, if a woman with PCOS comes with for oocyte donation, you can definitely use, because There also you can add, for the donor, you can add metformin and myoinositols to get a good quality oocyte. So this is a 32-year-old, para-1 living one. She has irregular cycles and weight gain. She has a three-year-old child and she's not planning for conception. How do you conceive? Counsel her, and what are the treatment options? Because she wants regular cycles. See, our women want regular cycles. Every month they want to bleed. That is their main intention. And you tell them you have gained weight, that is why you're having irregular cycles, they will not accept. They say we have irregular cycles, that's why we are gaining weight. So please regularize the cycles for us. So that time you have to get into this pharmacotherapy, that is OC pills, cyproterone acetate if there is hirsutism, drospirenone or levonorgestrel. Levonorgestrel for normal women, drospirenone, they have some acne and all those things, you can use drospirenone. Cyproterone acetate better for unmarried girls and drospirenone for women. So put them on OC pills boldly. In a nutshell, when you have PCOS, these are the symptoms: polycystic, irregular periods, hirsutism, irregular ovulation, and reduced fertility, obesity. So these are the diagnostic tests you do, hormonal, everything which I've told. This is all lipid profile, all those things I've told you. Then treatment is PCOS, fertility drugs, weight reduction. Then irregular periods, OC pills you can give. Hirsutism and all these things, you have to decrease the insulin resistance. You can give myoinositol and metformin. And then irregular and reduced fertility, IVF. And depending upon the patient, you can go in for treatment. Obesity, all that, lifestyle management, dietary, exercise, and if necessary, bariatric surgery, because drugs won't help that much. These people are really obese and they have to be tackled properly. So to conclude, obese, advise them weight loss, hyperandrogenism, hyperinsulinemia should be looked for, ovulation induction when you're doing add adjuvants, and customize. It has to be customized and individualized. You can't just do a blanket therapy here. Use metformin and myoinositols because this definitely improves pregnancy rates and ovulation induction rates. And of course, it reduces OHSS also, and use antagonist protocol if you're doing IVF. And AMH and AFC levels have to be done before. ART results in PCOS are comparable because you can get a good quality use site when you have to completely work up and give a proper tailor-made therapy. We can achieve pregnancy rates. Thank you very much for your kind attention.
Thank you so much, ma'am, for a wonderful, wonderful presentation. This is Dr. Kiran from Shield Healthcare, ma'am. Thank you so much for the beautiful presentation covering all the aspects, very comprehensive, ma'am. Ma'am, there are lots of questions. With your permission, I'll just read out the questions to you, ma'am. Ma'am, can you hear me?
I would be more than happy to answer questions.
Sure, ma'am. Ma'am, the first question is from Dr. Lillis, ma'am. She gives a situation where she talks about the ovarian volume, ma'am. The right side volume is 5.6 and the left side is 12.3. So in this situation, she wants to know, can we stimulate this patient, ma'am?
Am I audible?
Yes, yes, ma'am, absolutely.
No, they can hear me. Yeah, they can. But no answer from me.
Ma'am, can you hear me? Ma'am, can you hear me? Yes, yes,
yeah,
ma'am.
Yeah.
Can you hear me, ma'am?
Yes, I can hear you.
Yes, ma'am. Ma'am, the first question is from Dr. Lillis, ma'am. And she talks about the ovarian volume. She tells on the right side, if you have a volume of 5.6 and on the left side, it is 12.3. Can we stimulate this kind of patient, ma'am?
Yeah. See, you need to go and do drilling for this. One side, if you have a unequal ovarian volume, you can stimulate these patients because that means the ovarian volume of one ovary is just 5.6. So this will definitely produce an egg. You give ovulation induction. But if you give a little all these adjuvant therapy, then they will start ovulating and conception rates will definitely be good.
Thank you, ma'am.
And maybe if you ask to reduce weight, you have better results.
Thank you, ma'am. Ma'am, the next question is from Dr. Jay Chitra. Can pioglitazone be given to a lean PCOS patient instead of metformin?
Pardon? Which is the one?
Ma'am, can
Rosiglitazone.
pioglitazone?
Yeah, see, rosiglitazone was given before, but somehow I have not got very good results with that. Instead, I would say give them plain myoinositol. They respond very well.
Thank you, ma'am. Ma'am, the next question again is on myoinositol, ma'am. It is from Dr. Shobha. Which day to start and the dose of myoinositol and how long can be used?
See, the moment they come for ovulation induction, you give them 2 grams twice daily. Okay, and you have to give them minimum 3 to 4 months. By then, with ovulation induction, see, ovulation induction we start from day 2, but the moment you see the lady and you put her on a folic acid, you give her this myoinositol, definitely you'll get better ovulation rate and also pregnancy rates.
Thank you, ma'am. Ma'am, the next question is from Dr. Shireen. Can step-up protocol be given for IUI cycles?
Yes. See, what we do, we have a set protocol in our hospital. What we do is, when a woman comes with infertility and we know that she is PCOS, one is depending upon whether she is obese or not, we give her a combination of myoinositol and metformin, and if she is a lean PCOS, it is just myoinositol. And then 1 or 2 cycles, first cycle we try with the normal dose. Suppose they don't respond, then we can go in for step-up protocol. That's what I told you. That is first day 1 and second day 2, third day 3 and 4 and 4. But if you are doing an IUI cycle, or subsequently also you find their response is better for step-up protocol, you can go ahead and give. And IUI cycles also you get very good response. Instead of mono follicle, you'll get 2 to 3 follicles, which is ideal for IUI, and our conception rates are almost 50 to 60% with that.
Thank you, ma'am. Ma'am, the next question is there any meaning in giving letrozole 2.5 mg from day 2 today and till day 12 continuously?
Yeah, people have given. See, suppose you want to induce that lady for IVF and you want to do a low-cost IVF, definitely people have given up to 12, but I have not done that. I give up to 5 days step-up protocol and then add gonadotropins, but you can give up to 12 also. There are many studies which say that and have achieved good ovulation rates.
Thank you, ma'am. Ma'am, the next question is from Dr. Anju. She wants to know when you have an obese PCOS adolescent
Yes.
girl, ma'am.
Your voice has got stuck, Dr. Kiran.
Ma'am, can you hear me now? Hello? Ma'am, can you hear me now? Ma'am,
Question?
can you hear me now, ma'am?
Yeah. Which is this one?
Ma'am, we are not able to hear you, ma'am.
Can you hear me, Dr. Kiran?
Yes, ma'am. Yes,
Yeah.
ma'am.
See, obese or even for thin patients, metformin, metformin you don't give for thin patients, but obese patients, 3 to 4 months you can give them metformin. But I would always prefer a myoinositol combination. I'm not saying myoinositol because Field is doing this program. I am saying it because I give it routinely and I have got good results with that.
Thank you so much, ma'am. Thank you so much. Ma'am, the next question is from Dr. Prasanna. How long can we give OCP in an adolescent who is having irregular periods, ma'am?
Yeah. This is something which I commonly come across, and then see, it is depending upon the, the BMI of that girl. When an adolescent girl comes to you with irregular cycles, first important thing is counseling. And if the girl is about 16 or 17 years, just put her, if she does not have irregular cycles, fine. But if she doesn't have menorrhagia, you can just counsel her and put her on just adjuvants of iron and B complex like that. But if the girl is above 19, then she is having irregular cycles and you find signs of hirsutism, then please put her on cyproterone acetate combination. But when you put her on that, you have to specify and explain to her that this is a lifestyle disease and she has to have a healthy lifestyle, and this is temporary. For 3 to 6 months you can put her on that therapy. But what they do is they take that therapy, they are comfortable, and once the therapy is over, they come back with irregular cycles. It is mandatory for us to counsel them that you want regular cycles, your lifestyle has to be healthy. And we also have to insist on them saying that this is just not a disease now, irregular cycles. Future, it is going to go in for a lot of problems like infertility, diabetes mellitus, hypertension, cardiovascular disease, that metabolic syndrome. So we have to emphasize and really task. I mean, it has to be like a task that they have to lose weight and they have to take care of the disease, because this is mainly a lifestyle disease.
Thank you, ma'am. Ma'am, the next question is again from Dr. Lillis. Is it better to give inositol alone for a few months and then go ahead with clomiphene and metformin after that?
No, when you're giving myo-inositol, especially thin PCOS, you can start ovulation induction. Suppose they don't respond. Suppose you have a patient who is a PCOS and you give myo-inositol and they don't respond in the first cycle, then you can put her on OC pill for 1 month. And when she is on myo-inositol therapy only, please give ovulation induction, because that is when she is going to produce a good quality egg and her chances of conception is high. You lose track of her, you put her on myo-inositol and send her home, she is going to gain about 3-4 kgs more, or she may just take that therapy irregularly and may not come for follow-up if it is a lean PCO. So best would be to monitor them regularly and ask them to come for ovulation induction, because when you give ovulation induction when they are on this therapy, the conception rates are much better.
Thank you, ma'am. Thank you so much, ma'am. Ma'am, the next question from Dr. Lata, ma'am. What is the choice when it comes to dual trigger, ma'am?
Dual trigger.
Yes, ma'am.
Dual trigger in PCOS, we normally give 2 milligram of this lupride depot, and then of course HCG is given, because HCG is mandatory for maturation, oocyte maturation. So we either give 2000 or 5000 depending upon the E2 levels. And then of course, suppose you find she is going in for hyperstimulation after the womb pickup, freeze the eggs and then antagonize her again, because you know that antag completely blocks everything. It blocks FSH, LH, it blocks HT, everything it blocks. So you start giving antag, her symptoms of OHSS will come down and she may not go in for problems. So you give this dual trigger and antagonize her, then the things, the status of OHSS will not be there.
Thank you, ma'am. There are a few more questions, ma'am. Can we take or?
Yes, please.
Okay, thank you, ma'am. Ma'am, the next question is from Dr. Haresh. So he gives a case situation wherein you have a married girl who's 26 years old, and the patient is thin with PCOS. How many months the pill should be given without any child till now?
She's thin and her cycles are irregular?
They have not mentioned about the cycles, ma'am.
See, if she is a thin patient, newly married, and her cycles are irregular, and she is not keen on conception, you can put her on OC pills with drosperinone combination. But if she is keen on conception, she is thin, look at her ovarian volume. If the ovarian volume is just 10 and you give her ovulation induction, and you see good quality of oocytes coming, then you can continue. But if you are giving her a combination of drospirenone uh, as an OC pill to regularize her cycles, at least 3 to 6 months you can give her, because this 3 to 6 months is going to improve the oocyte recruitment, and also the increased LH level and androgenemia, all that hyperandrogenemia is going to come down.
Thank you, ma'am. Ma'am, the next question is from Dr. Mamta. If we give letrozole and there's a stoppage of the production of estrogen, will it increase the androgen levels?
No, no. Letrozole does not have any increase in androgen levels. It converts the peripheral fat. That is why it helps in obese patients. See, many a times obese patients may not respond to clomiphene citrate, whereas these obese patients respond to letrozole well, because it causes the peripheral conversion of estrogen, that is, which has come from the peripheral fat, and then it produces the ovulation. So that's why the results are good, and you get a monofollicular development. There won't be any androgen signs.
Thank you, ma'am. Ma'am, the next question is from Dr. Lalita, ma'am. You mentioned about OHSS. So in the treatment of OHSS, ma'am, what is the dosage of prednisolone and for how long do we give it?
Dosage of prednisolone, it depends once there is full-blown OHSS. But we give about 5 to 10 milligrams till the symptoms come down. But more than that, it is better to antagonize the patient. That is, the moment you finish the pickup, just look for the signs, give her IV fluids, let her take a lot of fluids, look for whether it is mild, moderate, and severe. If she's going for mild to moderate, then you can start IV fluids about 100 to 150 ml per hour, and then look for her urinary output. Then, of course, you can give her Estar IV, because previously we used to give albumin. Now it is not given because it's very expensive, but you can give her Estar. And then once you start antagonizing, giving antag injections, about 2 per day you can give. So then her symptoms will come down, and all her GI symptoms, when it comes down, you can send her home.
Thank you, ma'am. Thank you so much, ma'am. Ma'am, you discussed about dual trigger. So Dr. Savitri wants to know what are the indications for dual trigger?
Whenever it is a PCOS patient and you have E2 levels of more than 2,500 to 3,000, don't allow the E2 levels to go to more than 3,000. The literature says it is 4,000, but we have to be double careful because we want OHSS free clinics. So when it is between 2,000 to 3,000, then when you're giving HCG, you can coast. That is, you decrease the amount of gonadotrophins you're giving. So the E2 levels falls. You have to tell the patient that you may lose some of the follicles, which is okay, because there'll be about 20, 25 follicles. Even if she loses about 4 or 5 or even 6 or 7, that is okay. She'll be free from OHSS. So that time you give, in such cases, you give dual trigger. And we have seen very good outcome with dual trigger.
Thank you, ma'am. Ma'am, can cabergoline be given for 5 days in OHSS?
Yes, you can give, but I feel you can give cabergoline, no problem. 0.5 OD you can give up to 8 days post pickup. They say it helps. Yes, it helps. Okay. I'm not very confident about that drug.
Thank you, ma'am. Ma'am, you spoke about letrozole. So there is a comment from Dr. Shireen saying that letrozole shouldn't be given for more than 6 times for induction. Is it correct, ma'am?
Yeah, they say that. So most of the time they conceive. Suppose letrozole you can't give, you have given and she doesn't conceive, then at least 3 or 4 cycles, then you start looking at the other factors. You see a nice follicle, you see a nice endometrium, then your 3rd cycle she doesn't conceive, then you have to look for the other factors, and then maybe look at her tubes, of course, if she is a elderly patient, you can go in for a laparoscopy. Otherwise, if tubes are normal, then you can look for male factors Suppose everything else is normal, then you can go on for IUI. Suppose you have finished those 6 cycles, switch over to gonadotropins, low dose gonadotropins.
Thank you, ma'am. Lots of requests for the recording of this webinar, ma'am. So with your permission,
Yeah.
send them.
More than happy to give it.
Sure, ma'am. So I think with no further questions, we can wind up the session. I would first like to give thanks to Vidya ma'am for giving us such an extensive lecture and having so much of patience to answer each and every question which has come up, covering various facets of PCOS and its management. Thank you so much, ma'am, on behalf of Shield Healthcare.
My pleasure.
Thank you, ma'am. I would also like to thank the audience for a very, very patient listening. And I'm sure we will have more webinars with ma'am in the coming days. Thank you, ma'am.
Thank you so much. I would sincerely thank the officials of Shield Healthcare, Mr. Balaji, and all the other officials for this wonderful opportunity. Really enjoyed doing this. Thank you so much.
Thank you, ma'am.